I'll go ahead with the oops in evisceration surgery. So for us, just like cataract forms the bread and butter for most ophthalmologists, for an oculoplastic surgeon, evisceration is one of the commonest surgeries that we perform. I'm Tarjani Dave. I come from LV Prasad Eye Institute, and I do not have any financial disclosures to make. So regarding the oops in our surgery, I'm going to talk to you a little bit about evisceration. What are the petal or the scleral flap techniques, the complications that are routinely seen, especially with a focus on implant migration extrusion. Also a little bit on how we augment volume when we feel that the orbit is not optimally augmented in terms of volume. Certain other complications that we see, such as cysts around the implant and eyelid malpositions, which are common, and just give you a sort of a brief on the management paradigm in these patients as a summarizing slide. And I'm going to do this with 10 case examples. So not everything is video based here, but you will be seeing a lot of video. So this is an ideal outcome of socket surgery for us, where you see this lady with a bicycle eye who has a beautiful prosthetic eye placed with both the eyes looking fairly symmetric after the surgery. So this is what we call as ideal volume replacement. And how do we do that in evisceration? I just put up a collage instead of putting a video to sort of run you through the steps of evisceration surgery. Like nearly everybody would know, it begins with a peritomy, removing the corneal button, scooping out the contents of the eye. This is the important panel where we actually go ahead and make flaps within the sclera. These are known as sclerotomies, and each of these flaps is suspended by the corresponding extraocular muscle. So it's not a free tissue, it's held in the orbit by the extraocular muscle. At the posterior end, these flaps are divided from the optic nerve, and then we place the implant and perform closure of these flaps, followed by the closure of the conjunctiva and the tenons and placement of a conformer at the end of the surgery. So when you look at complications in evisceration, what are these? You may see complications associated with either the porous implant or the non-porous implant, which tends to give you 70% of the volume once you've performed the surgery. And the remaining 30% of the volume lost by removal of the eye is given by the prosthetic eye. We'll mainly focus on the complications seen with non-porous implant, because nearly 90% of ophthalmologists in our part of the world use non-porous implants. And these are mainly two complications. You see exposure, which eventually leads to extrusion of the implant, which means it comes out. And the second one is implant migration. In essence, this is just one series that we published, which told us that migration is not very common, but nonetheless, we went ahead and defined migration. So what is implant migration? When you see that the implant that you have placed is not central within the intracorneal cavity and has gone inferotemporally, that is what is termed as implant migration. And as you can see in this gentleman, the prosthetic eye is actually resting on the lower eyelid and not in the inferior cul-de-sac as it should normally do. So what was being done for implant migration all these years was to perform implant exchange. But we now know that even if you exchange the implant, no matter how many number of times you do it, the implant tends to migrate again into the quadrant where it initially had migrated. So what are the other options? You can either remove the implant and perform a dermis fat graft, but this requires you to give another large incision at another site on the body, which many patients may not be ready for. So what did we do? So crystal gazing into the future, we thought, could we manage this in an innovative way? And that's where we brought about 3D printing to generate customized implants. So this is a patient who's had 2 implant exchanges. Despite that, the implant has migrated again into the quadrant where it was originally. And then we put a customized implant there, which was fabricated via 3D printing, and that pushes the implant central. So what does it achieve? It helps you retain a prosthesis in the orbit and sort of corrects the implant migration. And how is this done? So essentially, we take the patient's 3D, we take his 2D CT scan and convert it into a 3D model, as you're seeing over here, via readily available online software. And this 3D model is then sent to a printer, which actually prints the entire orbit in life size. Once you have this orbit printed, it sort of becomes pretty easy to play around with it. So this is one of the 3D printers which is available. Looks like a very fancy machine, and is sort of, you know, very exciting to see it do the entire process, which takes somewhere close to 8 to 10 hours to print one model of the orbit. And if you would see over here, you can see a sort of rough outline of the orbit that is there with support material. This, when put in a water bath, the support material dissolves and then gives you the life-size print of the orbit, on which you can play around and generate implants using the traditional implant generation skills that are there in any oculoristry laboratory. And when this implant is then placed in the orbit, it helps you correct the migration. So this is for people who might be more interested to read through the technique. Now, what is the other complication that you see? One of the common complications is exposure. As you're seeing over here, the implant was nearly exposed. In that situation, you need to go ahead, remove the implant, dissect the entire tissue, free the sclera from the optic nerve posteriorly, essentially create petals of the sclera, which will then allow you to place in a larger implant and close the defect. So these are the petals being made with the residual sclera. And if you see the inner surface of the sclera, it is covered with a lot of fibrous tissue, which requires to be peeled out. It is this fibrous tissue that keeps contracting and pushing the implant into exposure. So a very sort of, bloody surgery, messy surgery, time-consuming surgery. This was removal of the necrotic sclera. You see that implant which was placed inside secondarily, along with closure. You tend to retain as much tissue as you can, even if the wound edges are ragged, they heal beautifully. Conserving tissue sort of becomes very important in this situation. And then when you might be left with a little bit of defect in the wound area, you can use a mucous membrane graft from the lip area to cover that defect and to give you the surface area that was lost. So this is the mucous membrane that has been transplanted into the socket. Typically, this is how implant extrusions are treated, and the outcomes are very gratifying. Now, few other oops in evisceration. One is when you have suboptimal volume augmentation. You see this lady who has sinking of the lower eyelid and this large sulcus deformity here, which can easily be corrected by placing a larger implant. So you exchange the one which was there inside for a much larger sized implant, and you see that her volume has built up. She has a little bit of ptosis, which can obviously be corrected later on. Certain other oops, there are some very finicky patients. This gentleman who has an excellent outcome but is worried about this deep superior sulcus following evisceration and little bit of enophthalmos, and is treated easily in the office by just a filler injection behind the eye. This is the point of entry of the filler. And just compare the sulcus here versus preoperatively, and you see that the sulcus has very beautifully built up. Similarly, a young girl who's worried about this sulcus deformity, in whose case we went ahead and injected some fat from the patient's abdomen to give her more permanent results. And in certain situations, you may not have any implant at all, just a plain evisceration is done. And there, where you build in the volume and build the surface with the help of an implant, you can see a reduction in the weight of the prosthesis, which sort of helps you bring the lower eyelid also back in position, because it's not bearing a very heavy prosthetic eye. Another patient with such lower eyelid retraction, which is simply corrected by placing an additional implant, such as a Porex wedge implant, into the orbit. Another situation that we also commonly see is protrusion of the prosthetic eye that can develop due to such cysts in the socket following surgery. And these can very easily be treated by just aspirating the fluid within the cyst and injecting a sclerosant into it, making it a 2-minute office procedure rather than undergoing a large surgical procedure. Probably the last slide that I have, last series of cases where you also see eyelid abnormalities in patients who undergo evisceration like this, where you're seeing a frank entropion. And in these situations, we go ahead and along with the evisceration also sort of perform a hard palate mucosal graft. This is the hard palate graft being harvested from the mouth of the patient, from the region of the hard palate, which is then transplanted into the eyelid to act as a spacer graft And this allows correction of entropion in the same sitting, giving very gratifying outcomes post-operatively. So that's the placement of the graft. It can be divided and used in both upper as well as lower lids, or can be sort of, contoured to fit your defect better. And this is the sort of outcome that you can get when not only you have a very nice looking prosthetic eye, but an excellent correction in entropion along with the evisceration. And the last part is about ptosis, which is also very commonly seen in anophthalmic socket surgery. You see the series of photographs here with the patient having ptosis with prosthesis, which is then corrected with minimal amount of levator resection. So in summary, in anophthalmic socket surgery, the nomogram that we follow is we correct the volume, we correct the surface, both of these via the several modalities that I told you, then assess if the prosthesis is good or not and change it, and finally address the eyelid to give you a much better cosmetic appearance than where you start from. Just to summarize, I have spoken to you about the different techniques of evisceration and the common complications such as migration, extrusion, volume loss, peri-implant cysts, and eyelid malpositions. Thank you so much.